I call the meeting to order, and today we're having a hearing on NASPR and safe drug disposal, and I'll recognize myself initially for an opening statement. The two important pieces of legislation that we're addressing basically deal with the growing crisis of abuse of prescription medications. First is the reauthorization of the National All Schedules Prescription Electronic Reporting Act, or NASPR. This is a bill that I believe the gentleman from Kentucky is the prime sponsor, but myself and others on the subcommittee have been involved with it in the past. And secondly is the Safe Drug Disposal Act. According to the 2010 National Drug Control Strategy put forth by the White House, prescription drug abuse is the fastest growing drug problem in the United States. Since 1999, deaths from drug use have more than doubled, surpassing homicides, suicides, and gunshot wounds as causes of death. And this increase in drug overdose death rates is largely because of prescription opioid painkillers. Deterrence of prescription drug abuse is complicated by the fact that prescription drugs are often obtained with ease from those closest to the drug abuser. Studies show that upwards of 70% of people who use prescription drugs for non-medical purposes got them from a friend or relative for free, for money, or by stealing them, sometimes unnoticed from the family's medicine cabinet. And many people, particularly teenagers, believe prescription drugs are safer than illicit drugs because they're prescribed by a healthcare professional. The Office of National Drug Control Policy, working with other federal, state, and local community partners, has taken a leadership role in promoting comprehensive strategies that ensure prescription drugs are only used for their intended purpose and that unused or expired medications are disposed of in a timely, safe, and environmentally responsible manner. Ridding the family medicine cabinet of leftover prescription drugs is easier said than done for a variety of reasons. I'm therefore particularly proud of an initiative in my state, New Jersey, last year, supported by the administration called Operation Medicine Cabinet. This was the first in the nation statewide. It's the first in the United States where we had a statewide day of disposal of unused, unwanted, and expired medicine. New Jersey residents and communities in all 21 counties participated in a public health initiative sponsored by the Drug Enforcement Administration, or DEA, in New Jersey. This was in the Office of the Attorney General and also in combination with the Partnership for a Drug-Free New Jersey. I should note that the huge success of New Jersey's program led to the creation of the American Medicine Chest Challenge, which is a national day of prescription drug disposal that will be held this November 13th. Today we'll hear from the administration on their support for the Safe Drug Disposal Act, which will make necessary changes in the Controlled Substances Act to make it easier for people to return unwanted drugs through the drug take-back programs. And this bill is the product of the hard work of Representative Inslee and also Representative Bart Stupak. Now, we're also going to hear from our distinguished panel today on their support to reauthorize the second bill, the NASPR bill. This law, which was originally enacted in 2005, created an HHS grant program administered by, is it SAMHSA? Okay, for states to establish prescription drug monitoring programs. PDMPs track drug prescriptions with the goal of preventing overuse and illegal diversion. Approximately 40 states maintain PDMPs or have laws that authorize their establishment. Starting in fiscal year 2009, Congress appropriated funding to support NASPR grants in 13 states, and the bill before us will reauthorize the program until 2013. I mentioned that NASPR was an initiative that Representative Whitfield, who's here now, worked on in 2005. You also, Mr. Shimkus, Bart Stupak, were involved in this. I think it's a good program. It certainly needs to be reauthorized. And so now I'd recognize Mr. Shimkus for his opening statement.
Thank you, Mr. Chairman. I want to welcome our panel this morning. I think these bills are another good example of what we can do when we work together. These two pieces of legislation will both aid in tackling drug safety issues in the United States. First, we will do so by reauthorizing the NASPR. NASPR addresses use and access problems. By reauthorizing this, we'll ensure funds remain accessible to strengthen existing state programs while new ones get off the ground. I was an original co-sponsor, as you mentioned, along with yourself and our colleague from Michigan, Mr. Stupak, and I want to really congratulate my colleague from Kentucky, Mr. Whitfield, who's the lead sponsor and the champion of the bill. His leadership has been very, very helpful, and I'm also glad he made it here on time for the hearing. We also have the Safe Drug Disposal Act, which will ease the cumbersome process of disposal of unused controlled substances. There is a system in place for safe distribution of controlled substances, and it only makes sense that we establish the same for the disposal of these drugs. Pharmacies and many others on the state and local level stand ready to provide these services in their communities if given the ability. The Safe Drug Disposal Act will create these avenues by working with existing framework of already up and running drug take-back programs. I support this legislation and thank the chairman for continuing to work with the minority to get language to a comfortable level for everyone. I also look forward to continuing to work together to help move both of these bills through the committee for consideration by the House. Finally, last week I mentioned the desire from our side to invite Dr. Berwick to testify before this committee. Obviously, I haven't heard a response yet, so we'll be formalizing a letter to Chairman Waxman for a request to do that. We know that Dr. Berwick is now officially in his role as CMS Director. He will serve as a key role. He's made some very interesting comments in the future, and we just need to have a chance to ask him if those comments are how he will operate in his new position, or if there's some change as far as the rationing debate and how we'll handle this new health care law. It is the biggest thing we've done since I've been here in Congress, and it's just time to start getting some questions answered on this. I'm not going to belabor the point, Mr. Chairman. You've heard it before, and I'll yield back my time.
Thank you. The gentleman from Georgia, Mr. Barrow. Gentleman waves. And next we have the gentleman from Kentucky. I think I should mention that he talks. Oh, Mr. Pitts. Oh, I'm sorry. Gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman. There's no doubt that prescription drug abuse and particularly abuse of controlled substances is a serious problem in our country. The cost to society is high in lost productivity and wasted lives, but also in direct costs to many government programs. In September of last year, GAO released a study on Medicaid fraud and abuse related to controlled substances. In just this one federal program, in just 5 states surveyed, GAO found the following. Quote, tens of thousands of Medicaid beneficiaries and providers were involved in potential fraudulent purchases of controlled substances, abusive purchases of controlled substances, or both, through the Medicaid program in California, Illinois, New York, North Carolina, and Texas. About 65,000 Medicaid beneficiaries in the 5 selected states acquired the same type of controlled substances from 6 or more different medical practitioners during fiscal years 2006 and 2007, with the majority of beneficiaries visiting from 6 to 10 medical practitioners, end quote. These activities, known as doctor shopping, resulted in about $63 million in Medicaid payments and do not include medical costs, that is, office visits, related to getting the prescriptions. GAO even found that according to Social Security Administration data, pharmacies filled controlled substance prescription of over 1,800 beneficiaries who were dead at that time. These examples come from just one government program, and they represent just one facet of the problem. But today we're addressing a tool that can be used to cut down on the fraud and abuse associated with controlled substances. The National All Schedules Prescription Electronic Reporting Reauthorization Act, or NASPR, allows doctors to access the controlled substances prescription history of their patients in an effort to detect and deter abuse. I'm pleased to be a co-sponsor of this common sense piece of legislation, which, had it been in place and funded during the time GAO was doing this study, might have reduced the amount of doctor shopping that went on, may have prevented some of these fraudulent prescriptions for controlled substances from being written, and may have saved taxpayers millions of dollars. I look forward to hearing from our witnesses. Thank you, and I yield back.
Thank you, Mr. Pitts. Mr. Green, I know you just walked in. Would you like to do an openings? No, I already tried him. He waived.
Well, then I'll give mine. They gave me
Gentleman
time.
from Texas is recognized.
Thank you, Mr. Chairman, for holding the hearing today. We actually have two committees, subcommittees that are dealing with health care issues, one in our first floor committee room. I apologize for being late. Appreciate the hearing on this direct-to-consumer genetic testing. Personal genetic testing kits for saliva. Oh, wrong one. That's the one from downstairs. We have the right one now, Mr. Chairman. For holding this hearing on prescription drug monitoring programs and the NASPR program, which Congress enacted in 2005. Our ranking member, Mr. Whitfield, was author of the National All Scheduled Prescription Electronic Reporting Act. I'm proud to have been a co-sponsor of this bill and support it when it came through our committee in both the 108, 109th, and again, and now again in the 111th. The NASPR was clear to us then as it is now on both law enforcement level and drug safety level. With state prescription monitoring programs sporadic and not interoperable, it's relatively easy for individuals who abuse prescription drugs to doctor shop for controlled substances or obtain prescription drugs illegally with little detection from physicians or law enforcement. Texas Prescription Drug Monitoring Program, called the Texas Prescription Program, was established more than 25 years ago in 1981. Each year, the Texas Prescription Program collects 3.3 million prescriptions and monitors Schedule II prescription drugs. During the first year of the Texas Prescription Drug Program enactment, the number of Schedule II prescriptions filled in the state fell by 52%. The program helped the state crack down on the pill mills and forged prescriptions, but it's clearly a law enforcement program and housed at the Texas Department of Public Safety. Without question, prescription drug monitoring programs offer significant benefits for law enforcement, but they should go hand in hand with drug safety and public health benefits. I'm pleased that we're here to discuss reauthorizing the program. I fully support the legislation introduced by Mr. Whitfield, Mr. Tupac, and Mr. Pallone. Additionally, we've discussed legislation introduced by Mr. Tupac and Mr. Inslee on drug take-back programs. I'm an original co-sponsor of Mr. Inslee's legislation, the Safe Drug Disposal Act, which amends the Controlled Substances Act to allow end users or caretakers of an end user to safely dispose of unused prescription drugs and over-the-counter drugs through the Drug Enforcement Agency approved state-run drug take-back programs. Current law and DEA enforcement of the Controlled Substances Act can make it extremely difficult for end users to turn over unused meds for safe disposal. DEA rules are very strict, and controlled substances can only be passed into the possession of law enforcement, which means they must be present at collection sites and drives. This requires a coordination of law enforcement as part of this effort, and it's impossible to have law enforcement at every collection site. There is also a lack of public awareness of this rule and on what constitutes a controlled substance. This is a barrier in properly disposing of unused medications. Today, unused meds are becoming a gateway to drug abuse, and flushing down the toilet can be harmful to our environment. We want to assist states and localities by facilitating the safe disposal of prescription medication. And I know Mr. Stupak and Mr. Inslee have been working to combine their legislation. I look forward to supporting their efforts. And again, thank our witnesses for being here, Mr. Chairman.
Thank you, Mr. Green. And now, Mr. Whitfield, I should tell you that Mr. Whitfield talks about NASPR all the time and is constantly trying to improve and implement the program since he first got involved. Recognize the gentleman.
Thank you, Chairman Malone and Ranking Member Shimkus. And I would like to thank also Gene Green and Bart Stupak, as well as Chairman Pallone and John Shimkus, because it did take a real effort to get this legislation where it is today. And I might add that there was a program initiated in the Appropriations Committee a number of years ago, around 2002, and they appropriated money that went to the Justice Department And that prescription drug monitoring program was primarily focused on law enforcement, which is vitally important. But the program had never really been authorized, and the Energy and Commerce Committee did have jurisdiction, and we were able to introduce the legislation. It's been passed. It's now there is now a monitoring program in 40 states, and we think it has potential to do a great deal of good for the American people, to provide information for physicians as they treat patients that go across state lines, and will dramatically improve the safety and effectiveness of our medical system. So I look forward to the hearing today. I know the markup is going to be later this afternoon, but all of us know how complex health care is and how difficult the issues are. And frequently when I'm at home, people ask me, well, you don't know anything about health care, so how can you be up there doing what you're doing? Well, fortunately, we have Dr. Gingrey, who is a doctor, and I guess Dr. Burgess. But also, some of us are fortunate to have some advisors that come up here as interns sometime, and we have one with us this morning that's working on our staff for a while, and it's Dr. Jason Pope, and he's right here. He's on the staff at Cleveland Clinic, and he's an assistant professor of anesthesiology at Vanderbilt. So I do want you all to know that we feel like we have some good, competent advice on a lot of these issues, and we're glad to have Dr. Pope with us for a while here in Washington, D.C. And now you go back and bounce my time.
Thank you. I should mention there's been a change of plans. I think we've notified the staff that our intention is to have the markup 15 minutes after the hearing. So I don't know when that's exactly going to be, but that we're trying to move things quick today if we can, so I thought I'd mention that. The gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, thank you. I thank Mr. Whitfield for his kind remarks about me and Dr. Burgess. I thank God for Dr. Pope, because our information is a little dated from the medical, and I'm sure that if Burgess was here, he'd say, well, Gingrey's is a lot more dated than mine. But in any regard, Mr. Chairman, thank you for holding the hearing today. Prescription drug abuse is a major problem in this country. In my home state of Georgia, the fact that a number of pain clinics were charged with illegally prescribing strong narcotics to patients is but one reminder that our country is not doing enough to curb this startling trend. Prescription drugs, when taken appropriately for a medical condition, can improve a patient's quality of life or help them cope with a debilitating illness. However, when they are improperly taken, they can lead to chemical dependency, certainly from these pain clinics, and subsequently great hardship, loss of job, loss of marriage, loss of home. I could go on and on. The two pieces of legislation that we are going to consider this morning have been drafted hopefully to address this problem, and I would like to thank the sponsors for their work in this area. Of particular note, I want to thank Congressman Whitfield for his continued efforts in electronic prescribing reporting through NASPR. It's been 5 years since Congressman Whitfield first championed the legislation into law, and I'm proud that I was asked to be a co-sponsor of these efforts here today. I believe that the reauthorization of NASPR is a necessary step in the fight to address prescription drug abuse, and it will give states the support that they need to help prevent the overuse and illegal diversion of prescription drugs, particularly pain medication. In addition, I'd like to commend the sponsors of the various pieces of legislation that the subcommittee will be marking up this afternoon, both those that I serve with here on the committee and those off of the committee, for their efforts. Given the nature of today's dual hearings, I'd like to take a moment and single out a few sponsors personally for their efforts. First, Chairman Stupak's legislation, H.R. 903, the Dental Emergency Responders Act of 2009. It's a common-sense solution to a problem that could benefit many during a national emergency. Therefore, I want to thank Chairman Stupak for sponsoring this legislation, and I look forward to supporting it today. Dr. Tim Murphy, my colleague on the committee and a fellow co-chair of the GOP Doctors Caucus, has advocated tort protections for volunteer providers, physicians, from this committee for a few years now, and I know our peers in the medical community appreciate his efforts. I look forward to supporting that bill, H.R. 1745, in committee today and as a co-sponsor going forward. To all my colleagues, I understand that the process that led us here today has been a bipartisan one, thank goodness, for a change. And for that, I'd like to commend Chairman Pallone and Ranking Member Shimkus for their efforts. And, Mr. Chairman, I'll yield back now.
Thank you, Mr. Gingrey. Okay, I think we're done with our opening statements. We'll turn to our two witnesses. Let me introduce them at this time. First on my left is the Honorable Gil Kurlikowski, who is Director of the Office of National Drug Control Policy. And then we also have Joseph Ranasizzi, who is Deputy Assistant Administrator from the Office of Diversion Control for the U.S. Drug Enforcement Administration. I can't believe I got those two right. Their names are so long. All right. We'll start. Well, you know, we have 5 minutes. We asked you to try to keep to 5, although you're the only two, so I'm not going to be strict. And then thank you very much. You can submit additional comments, if you will, for the record. And, you know, after you may get additional written questions from us beyond our what we question you today. So we'll start with Mr. Kurlikowski.
Thank you, Mr. Chairman and Ranking Member Shimkus, and the distinguished members of the subcommittee. I think you've already made it very clear about the numbers, the information that has been provided about, as the CDC has determined, the epidemic in prescription drug issues. So I'll move past some of that. But reducing prescription drug diversion and abuse has been a major focus of the Office of National Drug Control Policy since my arrival a little over a year ago, and we have made it one of 3 signature initiatives within the office. The significant contributing factor to the diversion and abuse of prescription drugs is the widespread availability. Many people are not purchasing prescription drugs from a drug dealer on the street. 2007 and 2008, among the persons aged 12 or older who used pain relievers non-medically in the past 12 months, approximately 70% report having obtained the pain relievers from a friend or a relative. So this problem doesn't lend itself to traditional interventions. And these drugs are originally dispensed, as Dr. Gingrey mentioned, for legitimate purposes, and too often the public's perception is that they are safe for uses other than those for which they are prescribed. And we have to help change that public perception and the societal norm to one where unused or expired medications are disposed of in a timely, safe, and environmentally responsible manner. One aspect of President Obama's national drug control strategy relates directly to the disposal of unused or unwanted prescription drugs, and the Family Medicine Cabinet is a significant source of diversion for those seeking to abuse prescription drugs. Yet the difficulty in disposing of such medications in a fashion that is simple, legal, and environmentally responsible has been a challenge. Currently, the federal government advises controlled substance users to dispose of controlled substances in one of 3 ways: to throw them in the trash after taking proper precautions, to flush them down the toilet in limited cases for the very dangerous drugs, or to participate in take-back programs, as had been mentioned earlier, oftentimes community-based with the approval of DEA and in conjunction with law enforcement. Well, this legislation that the subcommittee is considering today will facilitate the establishment of pharmaceutical take-back programs around the country by making a statutory change to the Controlled Substances Act. This step is required before the Drug Enforcement Administration can fully implement the legitimate take-back of frequently abused prescription drug products containing controlled substances. And such a step will greatly improve the ability of consumers to legally, safely, and securely dispose of drugs. The strategy also calls for the expansion of prescription drug monitoring programs. These statewide databases recording the controlled substances dispensed by doctors, nurse practitioners, and other prescribers is important. And reauthorization of H.R. 5710, the National All Schedules Prescription Electronic Reporting Reauthorization Act of 2010, will be a great step in that direction. Information contained in a PDMP can be used by prescribers to guard against prescribing 2 or more drugs that might have negative interactions, can be used by pharmacists or prescribers to identify patients who may be shopping for prescriptions to sustain a prescription drug addiction, and under specific circumstances by regulatory and law enforcement officials when pursuing cases involving rogue prescribers or pill mills. Prescription drug monitoring programs are authorized in 43 states, but only 34 state programs are fully operational. Each state's PDMP authorizing legislation determines where and how the PDMP in that state will function. We must ensure every state has a functional PDMP in place, prescribers and pharmacists regularly use these databases, and that PDMPs are developed with the capability to share information across state lines. In approving these, if these two measures are approved that are under consideration today, I believe it will be a tremendous step in the direction in limiting the harmful consequences of prescription drug abuse in this country. And I look forward to working with this subcommittee, and I look forward to answering any of your questions. Thank you.
Thank you. Mr. Ranasisi?
And distinguished members of the subcommittee, on behalf of Acting Administrator Michelle Linhart and the nearly 10,000 members of the Drug Enforcement Administration, I am honored to appear before you today to provide testimony concerning two very important measures that will help stem the growing tide of pharmaceutical-controlled substance diversion and abuse: the disposal of pharmaceutical-controlled substances from our household medicine cabinets, and the creation and utilization of prescription drug monitoring programs. Now, I would be remiss in not thanking Director Kurlikowski for his leadership in these initiatives and addressing the overall problem of drug abuse. Addressing the diversion and abuse of pharmaceutical-controlled substances continues to be one of the DEA's top priorities. One way to accomplish this goal is to help our communities dispose of unwanted, unused, or expired controlled substances that remain in household medicine cabinets long after they are needed. The medicine cabinet provides easy and free access to controlled substances by drug seekers and non-medical users, such as teenagers, and increases the risk of accidental ingestion and poisoning of children and the elderly. The Controlled Substances Act provides for a closed system of distribution with stringent procedures and on the procurement, distribution, and possession of controlled substances. As part of this closed system, all persons who possess controlled substances must either be registered with the DEA or be exempt from registration. Under the Controlled Substances Act, ultimate users or patients are exempt from the requirement of registration when they possess this drug for a legitimate medical purpose. Although exempt, this exemption does not allow ultimate users to transfer controlled substances to any entity, even if the sole purpose of that transfer is for disposal. Therefore, the ultimate user or household member is left to personally dispose of the controlled substance. In many cases, the drugs remain in the household indefinitely or are disposed of in an appropriate manner, potentially impacting the water supply and environment. States, counties, and municipalities have tried to develop pharmaceutical collection and disposal programs to address the problems resulting from unwanted and unused medicines in household medicine cabinets. These programs are beneficial in many ways, but the Controlled Substance Act provides for the collection and disposal of controlled substances in very limited circumstances. DEA has provided technical guidance to various law enforcement agencies' efforts to conduct collection and disposal initiatives over the last several years, but these operations were limited to specific cities or counties. As the chairman mentioned, in November 2009, DEA Newark, in cooperation with the Partnership for Drug-Free New Jersey, state and local law enforcement partners, and community coalitions, initiated Operation Medicine Cabinet. In just 4 hours, over 9,000 pounds of unused, unwanted, and expired meds were collected at law enforcement-run community collection sites throughout the state. In order to stop the diversion of pharmaceutical-controlled substances from the medicine cabinet, there must be a means by which ultimate users can transfer these substances to other entities for disposal. There are several bills pending to address this issue. In May 2009, the Department of Justice issued a views letter in support of H.R. 1359, the Secure and Responsible Drug Disposal Act of 2009. This bill provides a means by which ultimate users may lawfully transfer controlled substances to other entities for disposal, affords the Attorney General discretion to promulgate regulations, and provides the requisite flexibility to address collection and disposal in a comprehensive manner. Without this legislation, DEA does not have authority to create a regulatory infrastructure to support the transfer of controlled substances from ultimate users to others for disposal. Another initiative to address diversion and abuse of pharmaceutical controlled substances is the implementation and utilization of state prescription drug monitoring programs. Although these Programs vary from state to state. In general, PDMPs reduce prescription fraud and doctor shopping by providing doctors and pharmacists with information concerning a patient's prescription history while ensuring patient access to needed treatment. Doctor shopping by drug seekers is one of the most common ways individuals unlawfully obtain pharmaceutical controlled substances. A doctor shopper may or may not have a legitimate medical condition. He or she visits several doctors that ultimately prescribe controlled substances for the same medical condition. The acquired drugs are then used to feed addiction or for illegal sale and distribution. When authorized, PDMPs can assist law enforcement agencies and state regulatory bodies in the investigation of individuals involved in doctor shopping or medical professionals or individuals involved in the diversion and illegal distribution of controlled substances. Approximately 34 states currently have operational PDMPs. The DEA supports the establishment of these programs in every state and urges the states to work together to promote the sharing of this information from state to state. In conclusion, the collection, removal, and safe disposal of unwanted or unused medications from households and the expansion of PDMPs will reduce or even eliminate some potential avenues of drug diversion and ultimately limit the availability of medications to drug seekers and abusers. We look forward to working with Congress to establish a solid foundation for take-back disposal programs and support any effort to expand the implementation and utilization of PDMPs to minimize avenues for diversion while protecting the public health and safety. I thank the subcommittee for the opportunity to appear before you today and welcome any questions that you may have.
Thank you. We'll take questions now from the panel, and I'll start with myself. And I wanted to ask these questions of Mr. Kurlikowski. Basically, I wanted to ask about the National Drug Control Strategy first, and then about interoperability, and both relate to NASPR. With regard to your office, you recently released a new national drug control strategy, and I wanted to know, how do state prescription drug monitoring programs fit into that broader strategy, and if you can describe how the office will promote prescription drug monitoring programs through that strategy.
We've been very supportive of PDMPs, particularly as shortly after coming into office and having visited South Florida and looked at some of the problems that were occurring with so-called pill mills in that area, and then visiting with other states. The Department of Justice has been very good about holding the PDMP workshops, bringing people together. And, of course, in this legislation, it would require that the director of ONDCP be involved in the advertising to people about how PDMPs can be helpful and can be useful. And so we're supportive of them. We've seen them work. We've worked with our partners at the Drug Enforcement Administration and could not think more highly of them.
Okay. You know, Mr. Whitfield reminded me of the difficulties we'd had over the years that he struggled with, you know, how we had these sort of two different programs. And so my second question is, if you agree that the prescription drug abuse, that it needs to be considered a public health problem and not just a law enforcement problem, and what else is the office doing to reduce prescription drug abuse?
We've made it a signature effort in several ways. The first was that it actually, until and many members of this subcommittee have been involved in this, but it really hasn't been recognized for the dangerousness. When I was, and I'll just give you a great example of my own lack of knowledge, been a police chief for a long time, and I actually think I keep up with the literature and really know this stuff inside out. When I was told at confirmation that more people are dying from drug overdoses than from gunshot wounds, and that was being driven by prescription drugs, I said, well, you know, I really didn't know that. I tested a number of my colleagues, none of whom I'll name, to ask them if they also recognize the dangerousness of prescription drugs that were out there. Quite frankly, they did not either. And when I talked to judges and when I talked to prosecutors, they didn't either. So first, getting this front and center with the American public about the dangers. The second thing is working with the hospitals on the Joint Commission on Accreditation to help them develop protocols. We also have visited a number of medical schools. Quite often, we don't see an awful lot in the curricula for doctors throughout their training in recognizing dependence and recognizing addiction and in understanding some of those problems. So those are just a few of the ways, and there are others that are highlighted in the drug control strategy.
Okay. And then on the interoperability issue, the bill sets a new requirement that states specify a timeline for achieving interoperability of their programs with bordering states that participate in the NASPR program. And it also directs the Secretary to monitor states' efforts to achieve interoperability. I know that that's important. I know it also began because of some of the concerns that, you know, what they had in Kentucky, where people were just going to other states. So my understanding is that the office is not trying to encourage all states to have identical prescription drug monitoring programs. Is that accurate? Well, let me say this. Why is interoperability so important? Is it true that the office is not trying to encourage all states to have identical programs, but then can different states' programs achieve some level of interoperability even if they're not identical?
Mr. Chairman, I think that Kentucky led the way in working with the state of Ohio to absolutely address that. These statewide databases are important, and the fact that so much of the regulatory work is done by the boards of pharmacy and the medical boards, and having a one-size-fits-all is not something that we would recommend. That being said, the NASPR legislation is particularly helpful because it lays down essentially basic guidelines for what should be included, and so that exchange of information among the states would be the things that would be most useful according to the practitioners that use these in identifying this. And lastly, I would tell you that again in our visit to the pill mills in South Florida, a number of arrests that occurred through the HIDAs, which are part of ONDCP also, back in Kentucky, Tennessee, and West Virginia, were people that were traveling from those three states to South Florida in order to obtain such things as OxyContin.
So, but I mean, again, it's you don't see a problem in the fact that the programs aren't identical in order to achieve the interoperability.
I don't, as long as there is some basic information that can be exchanged electronically, so that those boards and those states that need that basic level of information can use them and utilize them to begin to slow down or even reverse this terrible problem that you've identified.
Okay, thank you. Mr. Shimkus?
Thank you, Mr. Chairman, Mr. Director. A lot of my questions were similar to what the chairman mentioned, but so obviously you feel that the prescription drug monitoring program is an important aspect of this fight. That's question one. And we're talking about prescription drugs. A lot of the problems, even connecting, I border Mr. Whitfield's district, and I also border southeastern Indiana. What about the whole meth issue and ingredients that are not prescription drug issues? You have the same venue same issue as states themselves are trying to limit and have lists to prohibit the pseudoephedrine purchase across state lines. Can you speak to that?
I can. As you know, Mr. Shimkus, the Office of National Drug Control Policy was not as particularly attentive to methamphetamine in its early years as I believe it should have been. And having spent 9 years in the West, I clearly recognized the issue of methamphetamine. I don't intend for ONDCP to allow that to happen again, and we want to make sure that we're on top of it. So methamphetamine in the grand scheme of our national drug issues is not as high as some other issues. On the other hand, when you're small areas in southern Illinois or places just outside Seattle were being devastated by methamphetamine, we should have been on top of it and moved more quickly. Congress did that through the Combat Meth Act. Unfortunately, what we're seeing is that now the people who are so good at purchasing over-the-counter or behind-the-counter drugs through false IDs, et cetera, are circumventing the Combat Meth Act. We have seen two measures of success so far. One is in the state of Oregon, which has made pseudoephedrine a prescription only, and their numbers of methamphetamine problems are in single digits as far as laboratories. And then recently, Governor Haley Barbour just signed into law in Mississippi similar legislation legislation to make pseudoephedrine a prescription only. There's no definitive evaluation, but certainly what we've seen in Oregon bears worth watching.
Thank you. Appreciate the focus and your expertise in having to deal with this. Let me ask Mr. Renazizi on, do you think the drug take-back bill allows DE to mandate that registered entities implement the establish a drug take-back program? Current registered entities, your evaluation, what do you think that this legislation does to them?
I think the legislation provides us with the opportunity to create a framework for drug disposal. When we create regulations for something like drug disposal, we don't try and specify who, what, or where. What we try and do is create a framework and allow people to fit within that framework.
Yeah, and just to follow up, the concern will be through regulations, mandates being placed on entities that currently don't have mandates, and then they won't have the funds to be able to implement that. That's the focus of this question, and that's why I asked that.
I don't think I could comment on how the regulatory process is going to proceed until we actually have a piece of legislation, and even then, because of the APA rules, the Administrative Procedure Act rules, I don't believe I could comment on them.
Well, and I agree, but part of this process is a two-way process.
Yes, I understand.
So hopefully people are listening to comments here to realize that we want to make sure that an unfunded mandate may not fall upon someone who's not expecting it.
I could assure you that through the notice and during rulemaking, we go through notice and comment, and we take all of those comments very seriously.
Yeah, I'm not asking you to commit yourself. I'm just using the bully pulpit to just make a point. Yeah. On these programs, who do you envision would run these programs? I mean, you've got to. Done some wargaming.
Absolutely. The problem is that the programs are such a hodgepodge of different organizations and groups, all surrounding law enforcement. At this point in time, while we have not decided who would run the programs, we look to the states and the state regulatory boards to assist us with those with the programs and kind of guide us along about what they would look at towards a program. So at this point in time, we always look to the states, and take their recommendations, to heart. So at this point in time, we would probably look to the states.
Oh, great. Mr. Chairman, that's all I have, and I go back.
Thank you, Mr. Shimkus. Mr. Green.
Or abuse. However, it's important to monitor the tracking programs to find out what's working, what's not. Is SAMHSA collecting information to help evaluate the NAFSTR program?
Mr. Green, I actually don't know what information SAMHSA is collecting, but I can tell you there are two things going on with evaluations of prescription PDMPs. One is, and it's a bit dated now, the 2006 study that was done that showed some benefits of the PDMPs. The second thing is that the CDC will be releasing, I believe, by the end of summer, some research and evaluation on PDMPs. I would tell you that they're not perfect and that we need to make sure that more prescribers are using the PDMPs. That will be a key aspect, and I think it's perhaps one of the weaknesses, but it's part of the responsibility for all of us, I believe, to get that word out to the prescribers that this is an effective, useful database, and if they do engage in it, it will help them a great deal.
Are there any federal efforts to evaluate the state prescription drug monitoring programs?
There are. The CDC effort is an evaluation of, and I don't know how many states, but is an evaluation of different efforts in some of the different states.
I have one more question, Mr. Chairman. Let me find it, though. Mr. Anazizi, as we've heard, the Controlled Substances Act does not create a pathway for patients and others with leftover controlled substances medications to return them to pharmacies or take-back programs for proper disposal. To address the resulting problem, you stated the DA has utilized existing regulations to assist law enforcement agencies to conduct community take-back programs. My question is, can you explain to us the logical issues and resource implications for the DEA in assisting these programs, and can you describe how these programs ideally would operate if we amended the Controlled Substances Act so the DEA could issue regulations to enable drug take-back programs to accept these controlled substances?
Okay, well, first of all, and I noticed somebody on the panel mentioned that it was DEA regulations, a problem with DEA regulations. It's not a regulation problem. It's a statutory problem. The statute prohibits anyone from, except for registrants, from transferring controlled substances. When an ultimate user obtains a controlled substance, he's exempted from the controlled substance, the registration requirement of the Controlled Substances Act. Because law enforcement has an exemption, also, they could obtain or take in controlled substances. Currently, that's the only way we could do this, DEA or law enforcement, working with communities. But the law enforcement officer, the law enforcement agency has to be present, has to take that drug. It can't be done by any other person but the law enforcement agency. I can't tell you exactly how the, since we don't have the bill yet, I can't tell you exactly how we would create an infrastructure. What I can tell you is law enforcement will still probably be involved, not so much on every take-back program, but they'll still have the exemption and they'll still want to be involved. I know that our law enforcement partners on all of these initiatives have been very straightforward with us, that they want to be involved because this is so important to them. As the director said, prescription drug abuse is a nationwide problem, and law enforcement is very aware of that problem, and they'll do everything in their power to remove those drugs from the illicit market. So.
Well, it would seem like we need to, particularly our committee and our jurisdiction, to provide assistance for folks so they can dispose of their prescription drugs, including controlled substances, in some way, instead of just flushing them down into the water supply. And in the studies we've seen, and I think a lot of people have, at the amount of prescription medication that's now in some of the water that's that ultimately we will be drinking, is one way. If we can make it easier for people to legally and safely return unused prescriptions. So I appreciate what you're doing, and thank you, Mr. Chairman.
Thank you, Mr. Green. Next is the gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman. Pardon me, Mr. Benazizi, expand a little bit on how individuals currently dispose of their prescription drugs. With respect to controlled substances, how are individuals allowed to dispose of prescription drugs? I mean, do you allow pharmacies to accept those drugs?
Pharmacies are not able currently to accept controlled substances back from their patients. That's just a requirement under the Act. The Act, again, allows for transfer of controlled substances from registrant to registrant. Since a ultimate user is not a registrant, a pharmacy cannot accept that back from them.
So how do individuals currently dispose of prescription drugs?
As the director said, there's three ways. Currently, ONDCP and HHS on their website, or ONDCP on its website, has a model for drug destruction. It involves taking the drugs, deactivating them in something like wet coffee grounds, wrapping them up, and then throwing them in the trash. There's also on both ONDCP and HHS website a list of narcotics and other controlled substances that may be flushed. Or there are ongoing law enforcement take-back programs in certain communities where they could drop their medicines off.
Okay. Mr. Kulikowski, NASPR sets standard for protecting patient privacy in the controlled substance monitoring program, including restricting who may have access to prescribing information. Can you speak to this issue? Do you think it's important to have minimum criteria among these programs with regard to patient information?
It's one of the things that I think makes NASPR such an attractive law. and that is that it's driven by the states, but it's clearly the states have taken on different issues regarding the blend between a law enforcement issue and a medical practice issue. And there's state medical boards that work very hard to make sure that the physicians or all the prescribers are following those rules and regulations. There are certain protocols then for turning over the information at the particular appropriate time to law enforcement. And at the same time, the states have made great strides forward under NASPR to make sure that that patients and professionals in the medical practice are that the privacy issues are protected. And so I think that that's a wonderful part of this of the legislation.
Now, NASPR requires that dispensers, like pharmacies, report each dispensing of a controlled substance no later than 1 week after the date the drug was dispensed. Do any states have real-time reporting in the controlled substance monitoring programs? And can you discuss the advantages or disadvantages of having a uniform real-time reporting requirement?
I'm not familiar with any of the real-time reporting requirements that that the states have had. I think that the one of the reasons for the 1 week position is that quite often, particularly if it's and this could apply more in rural areas, that the ability to have information stack up or pile up and not get entered into the database in a fairly timely manner could cause some difficulties both for a prescriber who wants to find out if in fact this patient was going to multiple other places in a short period of time, and that would be helpful. I think many times the goal would be, if it was online in real time, would be helpful.
Thank you, Mr. Chairman.
Thank you. Mr. Whitfield?
Thank you all very much for your time today in testifying on this legislation. And Mr. Ranazizi, early on there was some policy discussions and really some disagreements about whether this program should be at HHS or Department of Justice. As someone involved in law enforcement, do you feel that there are adequate safeguards in this legislation that you can have access to fulfill your needs and objectives?
And I'm no expert on NASPR legislation, but from what I understand, currently there are adequate safeguards for us, for law enforcement.
Because we do think that that is important, and of course I think the main thrust has been the safety of the use of prescription drugs, but we know that it is a serious problem, drug abuse, and I've had a lot of law enforcement people in my district, and I've actually been a little bit surprised at it, that have actually formed task forces now to deal with the abuse of prescription drugs. And I really was not aware that it was such a major problem nationally, but from hearing your testimony, it is one of the most serious problems. Is that correct?
Mr. Whitfield, you're absolutely correct. I don't think that the recognition has been there, and I think that spans across an awful lot of the populace about the dangers of prescription drugs and also about the problems that we're seeing from the abuse of prescription drugs. I think the most recent arrests in Kentucky, Tennessee, and West Virginia from South Florida, almost 500 arrests, really helped to highlight that. But, you know, I was during the National Governors Conference, I had a chance to visit with Governor Manchin, and he said that, you know, he said, I cannot go anywhere in West Virginia to a public meeting in which someone is not telling me about a prescription drug problem. So I think all of the time and the attention that all of the federal agencies, ONDCP, DEA, EPA, et cetera, have given to it to work with this subcommittee and the subcommittee staff on this legislation, both in PDMPs and also in takebacks, is a good example of getting the information out there. And it's a good example of really government being so responsive and listening to the essentially the cries of the public about this problem that will make us all safer And I commend the subcommittee for their work.
And do either of your agencies or departments have any ongoing programs that are active in working with local law enforcement to give them suggestions on how to be more effective in this area of prescription drug abuse?
Well, to start off, we reorganized the Office of Diversion Control and the field elements of the Office of Diversion Control and created tactical diversion squads, which are task force, state and local task force. We have 34 in operation right now. We hope to have, within the next year and a half, 65 throughout the United States. And all they will concentrate on is prescription drug diversion and chemical diversion. That's state and local cooperative, and where Kentucky State Police is a perfect example. KSP has been on the leading edge of going after tracking down people who are diverting controlled substances, and we work very closely with Kentucky State Police in the state of Kentucky. It's so important to address this problem as a state and local cooperative effort because of the funding issues and because of the fact that, this is one issue that we're not going to be able to do alone. So.
And Congress has recognized the value of high-intensity drug trafficking areas, the 28 HIDAs that are funded, and all of the HIDAs, which are comprised of state, local, and federal law enforcement, but also includes some aspects of prevention and treatment. All of the HIDAs are very much aware of the prescription drug problem, and in many of these areas have shown real leadership and innovation in attempting to both work on takebacks, to support PDMPs, but also to do the necessary investigation and enforcement when we have either doctor shopping or physicians, in fact, or prescribers, I should say, that may be abusing the law.
Thank you.
Thank you, Mr. Whitfield. Mr. Gingrey.
Mr. Chairman, thank you. And I'm going to ask a series of questions of both Mr. R and Mr. K. And you can call me Mr. G. First of all, the obvious, but what kind of prescription drugs are the most likely to be abused?
The opioid painkillers.
Yes, I have to agree with that.
And the reason I asked that, and yes, I expected that response. I have noticed that a lot of the legitimate, even legitimate doctors who are involved in pain management, a lot of these physicians start out their professional career as anesthesiologists, but not always. And you see so many of these pain clinics that are popping up, as both of you know, and opioids. But it was brought to my attention that a lot of these doctors prescribe methadone now for pain. And as I said in my opening statement, I'm a little bit dated. I haven't practiced for 10 years, but I was always thinking of methadone as what you gave people at these drug clinics where the hopeless addicts that could not ever get off opioids, and you would give them a prescription for methadone. Tell me a little bit about that, what your knowledge of that is, and your concerns, if any.
Methadone was originally created as a painkiller in the early 1900s. It became the gold standard for narcotic addiction treatment in the 70s, and it's now reemerging as a very, very fine painkiller, especially in certain areas where the drug is used in combination with other drugs. The problem with methadone, as I don't have to tell you, is the kinetics of the drug. The drug accumulates, and there are a lot of overdoses because of that.
It accumulates.
Yeah, it accumulates in the body. It stays in the body for a very long period of time. If a person is not familiar with or not following the doctor's instructions on how to take the drug, there could be overdoses. If the person is taking other substances with the drug, it affects the clearance of the drug. The patient could overdose. If it's an opiate-naive patient who's never had taken an opiate before, person could overdose. The drug is a very cheap, good pain killer, but it does have its issues if it's taken inappropriately without a doctor's supervision.
A two-edged sword,
yes,
if you will. Maybe Mr. Whitfield just asked this question about NASPER, and of course Chairman Pallone and Ranking Member Shimkus, along with Mr. Whitfield, have done the major work on NASPER and leading up to this reauthorization. But do you feel that this will help in regard to all of these concerns with abuse of prescription drugs, particularly the pain medication like methadone and other opioids?
It's not the silver bullet, but we have seen success in these programs. Well, we think it has to be done in conjunction with a lot of the other things that were mentioned, the education of the public, both NASPER but also the Take Back, I think, is a wonderful combination for Congress to take on and to move forward. I think we can actually we took a hard look at the 10 months before I was in office and the 10 months after I came to office about the number of mentions in the press about prescription drug. And it was a significant increase. So I think the more, and as Mr. Shimkus said, using the bully pulpit that you all have to bring this to the attention of the public, and Dr. Gingrey, you in particular, having that medical background, you serve as wonderful spokespersons to alert people to dangers that perhaps they just really have not recognized.
Well, I thank you for that. Those not kind words. In fact, I've got a chemical background as a Bachelor of Science in Chemistry and a medical background. I had no idea that you could wrap up that medication with coffee grounds and throw it in the Can you tell me a little bit more about how that works? And if that information is on your website, how many people are going to go look and find that out and then all of a sudden start rummaging through the trash cans looking for coffee grounds?
Well, I think that's the real benefit of this hearing today, and the real benefit of also the work that as you said, Chairman Stupak did and Congressman Inslee have done on working on a clear, simpler, more easily understood take-back program. I think that's tremendously helpful. There are some of the drugs that are so potent and that can be absorbed in the skin that EPA, FDA, and ONDCP have recommended that they be disposed of by flushing down the toilet. There are others that need to be, as you said, made in combination with other things that are in the garbage that would make them particularly unattractive to be able to use. But having the take-back programs that are widely known and thought of, I think will be a big help.
Well, I think so, and I appreciate that. I know my time has expired, Mr. Chairman, but yeah, I don't want to see people rooting through the trash can or the toilet bowl, for that matter. So I like the take-back program. I yield back.
Thank you. Let me ask unanimous consent to include in the record the annual report of the Operation Medicine Cabinet New Jersey. This is the Partnership for a Drug-Free New Jersey program that I mentioned before. Without objection, so ordered. And now we have joining us with the subcommittee today, Mr. Inslee, who is the prime sponsor of the Safe Drug Disposal Act legislation that we're considering. Mr. Inslee?
Thank you. Thanks for letting me join you. Before I ask a couple of questions, a couple of great witnesses, I just wanted to thank some people involved. This has been a great team effort, bipartisan. Particularly, I want to note Bart Stupak, who's been working for a long time on this issue. Bart now, at the end of his congressional career, will be known throughout history not only as making the greatest catch ever in congressional baseball history in the Republican dugout, but also championing this issue, and I really want to thank Bart's leadership on this. Representative Stupak, Waxman, Rand, Baldwin, and Pallone, it's just been a great effort. I think we've got a good product here, and I appreciate the two witnesses, so I'll ask a couple softball questions if I can. First, Mr. Kerlikowski, we're having a heck of a time filling your shoes back in Seattle. We're trying. It's really tough. We might have to hire 3 people, actually, to fill your shoes, and I appreciate your work on this. I just wonder if you might comment on the importance of making sure that the programs that we do design are accessible and are easily accessed by communities and giving communities flexibility and how they're going to design these programs. Just wonder if you might want to comment on that.
I do. Your work and initiative on this, along with Congressmember Stupak's work, has been particularly helpful to us. I'm really so impressed with the Safe Drug and Disposal Act that's being considered, because it really is a kind of a whole of government approach, and we often sometimes hear that government doesn't listen or pay attention. This is a model bill. One of the things that I think will be particularly important is that we work very closely to make sure with the Department of Justice and the Attorney General's office that the programs that are put into effect make sense, are easily understood, and more importantly, are evaluated and used, and for helping to rid the medicine cabinets of some of these dangerous drugs, and rid them in a way that is, as you have remarked to me on a number of occasions, gotten rid of in a way that is very environmentally sensitive, and make sure that we are protecting the environment. This is a wonderful opportunity for us to do a better job of protecting the public, and to bringing to their recognition some of these dangers. And as the process, with the passage of this, as the process moves forward, we will be particularly attentive to the concerns that you have raised throughout the formulation of this legislation.
Thank you. I appreciate it. Mr. Moronesizi, I wonder if you would like to comment on the number of options that will be available, the number of locations where these take-back programs may be appropriate. Do you just want to give us thoughts on that?
Again, it'd be premature without the legislation being actual statute to comment on it. However, I could tell you that we've said all along what we'd like to do is create a regulatory infrastructure that is not specific to one or two or three different programs, but allows the states and entities within the state to create a program within those guidelines to fit the needs of their citizens. And I believe we could do that if given the opportunity by regulation, that flexibility to do that.
We'll look forward to that. Again, thank you for your work. This is a big deal on a bipartisan basis. Actually, I think last week I saw a headline in Seattle that prescription drug abuse became #1. As far as abuse, I think, in the state. So I know this is happening nationwide. We appreciate your work, and thanks for all the bipartisan work, our teammates. Thank you.
Thank you, Mr. Inslee.
Chairman Malone.
Sure, you want
Malone. No, I just ask unanimous consent that each member have 5 legislative days to submit additional letters of support.
Absolutely. And also, I'd remind our witnesses that you may get additional questions from members. I asked the members to submit those additional written questions within 10 days or so. So you may get those additional questions from us.
Mr. Chairman,
yeah.
And I asked just for a second, because Oregon was mentioned, and it's prescribing with pseudoephedrine, and that's an issue that we've talked about before, and we'll have current debate, especially in the healthcare arena, and access to family, cost of drugs. But I think it's also important to note that there's been an increase in Mexican drug meth cartel in Oregon at the same time. So there may be some benefits on home cooking. There may be an uptick in Mexican drug cartel, and it's important to keep that in the record.
Sure. Thank you. So anyway, thank you very much for your input. We're actually going to go to markup pretty soon on the legislation, so this was very helpful to us. I appreciate it. Let me mention to the members, we're supposed to have a vote, I don't know, any minute, I guess, within the next 5, what time? 2 votes within the next few minutes on the floor. So what I would ask is that we come back here about 15 minutes after the floor votes, and then we'll begin the markup at that time, which is not only on these bills, but some other bills as well that had previous hearings. So without further ado, thank you all, and this subcommittee hearing is adjourned.
Please give us an answer. They're going to get paid or not?
They will get paid. I'll speak for the Army. What we're concerned about is our civilian, many of our civilian workforce in some of these O&M accounts. That's our chief concern.
Okay, so for the Army, the soldiers get paid, but civilians may be furloughed and not paid. Secretary of Work, what about the Navy? sir, as you said, we've sometimes dealt with having to shift O&M monies at the end of the fiscal year, but quite frankly, the department was expecting the supplemental to be before the 4th of July. We weren't, there was really no serious thinking that it would go beyond the summer recess. And so our analysis, which isn't complete, as I said, we would shift into an emergency mode if the supplemental was not passed. As Secretary Westfall said, the first thing that would happen is we'd have to probably furlough civilians without pay. And in mid to late September, there is a chance that we would run out of money to pay active duty personnel.
Sailors in uniform would not get paid. Secretary Conson, how about the Air Force?
Mr. Klein, it's very similar to what Secretary Works said. If we still did not have money the third week of September, that's when the military manpower accounts would be affected.
So the pilot, the bomber, the attack pilot in Afghanistan would be asked to fly those missions and would not be paid.
If we go beyond the third week in September.
Thank you. I yield back.
Mr. Andrews. Chairman, these are all the reasons why I'm confident the supplemental will be quickly enacted.